Hello. I'm Dr. Omar Bey, and this is the OBHealthy. We are here because we are a group of physicians, African American and Black physicians, that are here to educate the population about health. All right. Our goal is to improve health in people of African descent. Number one. Excuse me, I got a little congestion in the throat there for a minute, and to encourage young Black males to consider going into medicine. That is so important because we really need the young males of African descent to think about medicine as their career. All right. Note that our webinar is every second Saturday at 1 o'clock. And what we'll do is also note that you can type in, and when you come into the webinar, you will be able to type in your question. And that's so important that if you have a question, type it, because we are definitely trying to answer each and every question that comes through. All righty. If you've missed a webinar, you can go to OBHealthy on YouTube and understand that you can see all of our past webinars. It's important to subscribe so we can maintain our level on YouTube. All right. Okay, I'd like to thank OBHealthy, number one, for allowing us to use their platform to bring this to you every second Saturday. And also, the most important thing that I can say is do not change any aspect of your medical care, no matter what we say, until you consult your physician. Understand only your physician can best treat your medical problems. All right. So I think that's all that I have to say. What we are doing today is we're going to have physicians coming on after we start. Several of the physicians were still at the hospital, and it's unfortunate that that's the way physicians are. We have to rock and roll the way it's handed to us. All righty. I would like each and every one of us to introduce ourselves. Dr. Atherley, can you start as far as introduction is concerned?
Fair enough. Good afternoon, everyone. My name is Trevor Atherley. I'm a cardiologist, interventional subspecialty in cardiology, and predominantly based out of Newark Beth Israel Medical Center in Newark, New Jersey. It is my pleasure to be here with you today.
All right, thank you. As far as, next will be Dr. Court.
Good afternoon, all. Dr. Court, my practice is in internal medicine. I'm located at East Orange, New Jersey.
All right, thank you. Patrick, Dr. Anderson, unmute.
Hi, everyone. It's Dr. Anderson, Patrick Anderson. I'm a gynecologic oncologist. I take care of women with cancer, and I practice out of Newark, New Jersey, and out of South Orange, New Jersey.
All right, thank you. And Dr. Aluya.
Well, Nelson Aluya, it's a pleasure to be here once again with my esteemed colleagues. I'm medicine and pediatrics trained, assistant professor of medicine at Newark Jersey Medical School, and also an attending physician at Newark Beth Israel Medical Center. I call myself a medical advocate.
All right. All right, thank you, Dr. Aluya. Excellent. And I see Dr. Clark has come on.
Yep.
Can you introduce yourself?
Sure. Dr. Kevin Clark. I'm a surgical oncologist. I work at the Newark Beth Israel. Glad to be here.
All right, thank you. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a subspecialty in nutrition. And we are so pleased to have everyone who's come on this morning. Welcome, welcome, welcome. What we're doing today is we're going to have a special topic. And I'd like to start off with this special topic. We're going to highlight one of our physicians, Dr. Patrick Anderson. And actually, he's going to talk, we're going to ask him questions as well. And hopefully the community out there that's looking at us will ask questions as well. We're going to talk about fibroids, all right? And Dr. Anderson, let's just start off with the basics. Let's start off, what is a fibroid? Just give us some understanding.
Fibroids are typically non-cancerous tumors that grow or afflict women. They grow primarily in the muscle of the womb. Now, typically in the body, there are two major types of muscles. There is what we call skeletal muscle, which we know we use to move our limbs. And then there are smooth muscles. Smooth muscles, muscle that support organs such as the heart, certain parts of the wall of the intestines. And certainly the wall of the womb is smooth muscle. Fibroids are smooth muscle tumor. They develop in cells called myocytes, which are smooth muscle cells. And once those cells are transformed, they tend to be sensitive to sex hormones such as estrogen and progesterone, which is made in the woman's ovary, or any other system that produce these sex steroids, such as some malignant tumors that can produce some of these steroids. And these hormones stimulate these cells, and these cells grow, and they can grow to tremendous size. Now, they don't have to get to be very large to be symptomatic. Now, there are certain conditions, for example, pregnancy, which are considered hyper or elevated estrogenic states. And during these time period, these tumors tend to grow more rapidly. So it's not unusual for a pregnant woman to start having symptoms such as pain because of the rapid growth.
All right. The thing of it is, you said a word. You said tumors. I want the other docs to chime in this as well. You said tumors. Is a tumor a cancer? You said this is a particular tumor. Tell me about that, doc.
Tumors are generally fall in two categories: cancerous tumors or non-cancerous tumors.
Okay.
Fibroids are in general non-cancerous tumors. The overwhelming majority of them are non-cancerous tumors. However, less than 1% of them can undergo malignant there are conditions that are not cancerous that behave in a malignant way, but less than 1% of these can become cancerous.
Okay, and that's a very small amount, what we're talking about there. Any of the other docs have any questions?
Yeah,
I have multitude of questions.
Often enough, Dr. Anderson, thank you for that very basic but very insightful explanation of what fibroids are. And being Black and I work in a Black neighborhood, I see a lot of this in women, and a lot of them, other than the signs and symptoms that they presented, which we'll talk about, are predominantly Black. Is fibroid a Black person's or Black woman's disease, or other people, other races get fibroids too?
Well, like every other medical problem, as we continue to figure out this human genomic pathway, we realize that every disease is a genetic disease. What we do know from an epidemiologic perspective, up to 70% of all women will develop some form of fibroid of varying types, varying sizes. Mm-hmm. However, in the Black community, they're typically 2 to 3 times higher than in other races.
Mm-hmm. Mm-hmm. Yeah.
Dr. Anderson, you mentioned that there are several layers in the uterus. Can you comment on where they're located? The first one be epidermis or what?
So typically,
where is the muscle layer located?
Yeah. So the womb is really a muscular organ, as most women will tell you. During that time of the month when they get their menses, incredible cramps many women suffer through. And it's as a result of the contractility or the robust contractility of the uterus. Dr. Atherley will laugh, but him and I have had this conversation. We said the heart and the uterus is probably really function the same way in their efforts. When stimulated, they contract very strongly. But the majority of the uterus is muscular. The outer layer is called the serosa, which is similar to like a very thin cellophane or plastic layer, followed by that thick muscular layer. Then the inner layer is the endometrium. The endometrium typically is the more hormonally responsive layer. That's the layer that monthly and weekly that layer, the characteristic changes in response to the varying amounts or level of the different hormones that's released or produced by the ovary, or any ectopic, meaning tumorous growth in other parts of the body that may produce those hormones. Now, typically, the menstrual cycle that most women experience is the response of that inner layer, the endometrial layer, to the the varying levels of the hormones. And it goes from the time of ovulation, where it's stimulated to become thick and blood vessel rich to accept a pregnancy. And if a pregnancy does not occur, certain hormonal changes occur and that layer gets shed, and that's what's manifested as the menses. So essentially, those are the three layers of the uterus itself. Now, the cervix, which is the mouth of the womb, is made up a little bit differently in that it has some of the same smooth muscle, but it's primarily fibrous tissue.
Okay, and what is usually shed during the menstrual period?
The endometrium, the inner lining of the uterus.
Okay, all right, excellent.
Patrick, did you talk about how to treat it?
We were just working through the background, through the
Because there's a question,
epidemiology.
actually one of the questions that was asked, a patient had a myomectomy and she's concerned about it coming back, and whether or not she should have a hysterectomy. So if you can go through exactly how to treat it. Is it only surgical? Are there non-surgical options?
Yes, so fibroids, fortunately, and as in management of most tumorous growth, whether cancerous or not, the goal in young patients is usually to try and preserve fertility. But in spite of fertility desires, many women, in spite of age, I should say, many women often don't relish having the surgical option. So there are various ways to treat fibroids. Now, there are several types of fibroids. Let me go there first. There is what we call the pedunculated fibroids, which, if you can imagine, the pendulum of a clock. And essentially, it's a fibroid that hangs off, a various location of the uterus on the abdominal side, the serosal side, and essentially it can swing like a clock. Now, these types of fibroids can be problematic, but typically don't cause the same symptoms that most other fibroids will cause. Now, what are those symptoms? The most common symptoms of fibroids is abnormal bleeding, irregular, and even when the bleeding is regular and associated with the menses, it's often very heavy. It can be associated with significant cramping and significant pain. The pain usually occurs as a result of what we call degeneration. Sometimes these fibroids outgrow their own blood supply and they degenerate, kind of like, what happens to the heart when it's devoid of blood flow. Hence, one more similarity. Now, by the way, we can also have fibroids in the heart. We've had a few interesting cases with these tumors growing in the chambers of the heart. So one of the things that can happen with these pedunculated myomas is they can tort or twist, and as a result, cut off the blood supply. Now, when that happens, sometimes they just fall in the peritoneal cavity, nothing happens. Sometimes other organ system becomes attached to them as a result of the inflammatory process. And, it's not unusual to develop conditions like a small bowel obstruction because a loop of small bowel gets wrapped around it. We've seen one as early as this week. Then there is the intramural ones. And what that means, intra means in the wall, in, and mural means wall, so in the wall. Now, depending on the size, it can either go from the serosal side to the endometrial side, that's transmural. Or it can be partially on the serosal side, but significantly in the muscle, or it can be on the endometrial side and partially in the muscle. And then there are the ones that we call submucous. Submucous ones are the ones that grow into the cavity. Now, one of the reasons they cause abnormal bleeding, like every tumorous growth, they secrete substances that has what we call angiogenic properties. And some of these, the role of these angiogenic properties is to create new blood vessels which afford nutrition and allow growth of these tumors. Now, with this angiogenesis, that obviously will bring extra blood supply into the uterus, and as a result, often causes extra bleeding. One of the ways it causes extra bleeding is just by virtue of increasing a surface area over which bleeding can occur. And also by growing, it also distends or extends the size of the uterus, creating a much larger uterine cavity, thus increasing the surface area over which bleeding can occur. So now the reason I went into the different types, because that also can influence the treatment modality offered to a particular patient based on their own unique circumstance. So typically in a younger patient, and let me just back up a bit, these tumors, as I mentioned before, are hormonally sensitive. Now, the peak of the hormonal production and the higher the hormonal malaria, that occurs usually after menarche. Menarche is the point at which a woman starts to menstruate. And it usually declines after the menopause. So it's typically, fibroids don't develop during teenage years, even though we've seen a few rare situations. And the peak of growth occurs during the reproductive years. And typically, if a woman has not developed fibroids by menopause, she typically does not develop them during menopause. So if a woman develops a myomatous or fibroid type growth after menopause, that could be a signal of that of some sort of a cancerous condition that's developing. Now, usually, because these occur during the peak reproductive years, many women have encountered the dilemma as to how to deal with the symptom of fibroids while preserving their reproductive ability. And as such, there are several ways to manage these fibroids. Typically, when reproduction is an issue, a surgical approach is typically offered. And the reason for this is there are several ways to manage these medically. Typically, the medical management does not take the fibroid away completely. And usually, many of these treatments are time sensitive, meaning you can only treat for a certain amount of time with these medications before you can impact other systems in the body. For example, when you treat with some of these anti-estrogenic agents, what can happen in the long run is many women can develop osteopenia or thinning of the bones earlier than usual. And as a result, that medication has to have a timeline. Now, sometimes what happens when you stop these medications, you get what we call rebound growth, meaning the fibroids grow faster and larger. So if fertility is important, then oftentimes surgery, the surgical option is the better option. And that surgical option allows us to preserve the uterine function. And we would operate on these patients, whether we do it via the open approach or the laparoscopic approach, we would remove the individual fibroids. But bear in mind that when we do that, we're removing the fibroids that we can see or feel, which means that any myocytes which have already undergone transformation can grow again. And the incidence and the rate is individualized. It depends on how many, the location, and the age of the patient after surgery. Now, for women who want to preserve fertility, who doesn't want to preserve fertility, there's also some non-surgical options. The more prominent one is what we call the UFE or the UAE, the uterine artery embolization, or the uterine fibroid embolization. And that's usually performed by an interventional radiologist. And using some imaging techniques, what typically happens is they isolate the blood supply to the dominant fibroids, and they often put little pellets into the vessels and thus cut off the blood supply, devoiding them of nutrition. And these fibroids usually shrink. And usually the incidence of the response rate is usually about 40 to 50% of women, the fibroids will shrink and the bleeding, heavy bleeding will cease. Now, the ultimate surgical approach, obviously, is the hysterectomy. And who typically is recommended for having a hysterectomy? So, for example, a woman who's had multiple myomectomies, a woman where there is imaging characteristics that suggest, and I say suggest, that there may be malignant transformation. Women who have already undergone their childbearing and is absolutely sure they don't want to have any more children. And women who are having rapid growth, especially the ones who are perimenopausal or postmenopausal. Because in that setting, you want to be absolutely sure there is no cancerous transformation that has occurred.
Oh, excellent, excellent.
Patrick, one question. Patrick, I have a burning question.
Okay, Dr.
Yes.
Clark.
Okay. When you take out the specimen, how does a pathologist describe the fiber? What is it? Is it only muscle there or what?
So the typical reading you get from a pathologist is
fibroid. Yes.
Is fibroids. However,
What does
when
that mean?
there are features that could suggest that there may be some other untoward transformation, then they'll tell you size, they'll tell you if there is necrosis, meaning areas of dying cells. They'll tell you what we call the mitotic rate. And if we remember from biology, when we look at cell structure, you look at the cytoplasm and the nuclei. And within the nuclei is usually where the DNA duplication occurs. And oftentimes we count these as mitoses or mitotic figures. And when there are mitotic figures, there is a criteria that tells us whether this is this particular tumor has undergone malignant transformation. And then the degree of aggressiveness or potential aggressiveness of this malignant transformation. So for example, the typical cancer that develops in a fibroid is called a leiomyosarcoma. And there's high grade and low grade. And then there's what we call cellular myomas. So cellular myomas usually are the ones that have mitotic figures less than 5. And the ones that's between 5 and say 10 mitosis per 10 high powered field is usually the low grade leiomyosarcomas. And the one above 5 is usually considered the high grade. And that has prognostic information intrinsic in that, in conjunction with other genomic properties that we often study. Now, in many patients, sometimes patients who have undergone myomectomies, meaning removal of the fibroids and leaving the uterus behind, when we get these readings from the pathologist, sometimes we're tasked with saying to the patient, listen, you know, the fibroid have undergone these changes, but they're mostly cellular. In that case, you can reassure them that it's okay to leave the uterus in situ with continued monitoring. Now, in cases where the mitotic activity is much higher, then it comes with some counseling. The difficulty there is in young patients. And it's a hard conversation to have with a young patient to say, listen, these fibroids are cancerous and the whole uterus needs to be removed.
Excellent.
Can I ask a quick question?
Sure.
I'm pleased to see your comparison of the uterus to the heart. Fortunately, in the heart, we don't have fibroid tumors as much. In any case, what I want to ask is about the dangers of the various kinds of operations that you mentioned, specifically because ever so often I'm asked to clear a patient for surgery for fibroids. And to what extent is the kind of surgery that you recommend, whether limited or total hysterectomy, for example, to what extent is that influenced by the patient's other medical problems, such as heart disease?
Yes. So, you know, that's a really good question, and it's very complicated. You know, and Dr. Clark often is involved in some of these cases because oftentimes when we have patients with these huge fibroids, you know, it's not just the fibroids. The fibroids can be associated with other medical conditions. So, for example, there are patients who walk around with hemoglobins of 4 and 5 because they bleed so heavily for so long. And many of these patients, you know, because the heart compensate for the anemia, the ones on the older end of the spectrum sometimes have some element of heart failure as a result of this continuous high output condition that it encounters. We can call that high output failure. So, you know, in these patients, often it's also, when you look at the population of patients who are mostly afflicted with this condition, you know, they're often also afflicted with hypertension and diabetes, which often influence cardiac activity. And oftentimes, you know, sometimes during the preoperative workup, we may encounter an abnormal EKG that ultimately, when we asked Dr. Atherley to take a look at it, he said, listen, this patient needs a cath because I don't like, there's ST elevations, you know, and I've often say, I don't fix hearts, I break them. So I'm glad to have a guy like Dr. Atherley and Dr. Court around. And oftentimes, as part of the workup, when you do your echo or your stress, as depending on what's needed, you realize that because of the long-standing condition, fibroids in conjunction with other things, these patients have suboptimal cardiac function. So as a result, you know, when you work these patients up, young or old, you really need to do a good physical exam. And, you know, sometimes I often say, you know, you should never see a physician, no matter who it is, walking around without a stethoscope and without learning how to use them, because we must always often listen. A patient has high output failure, you can hear a murmur, and we hear it a lot. Now that said, there's also other conditions, such as we know that these fibroids, not only do they react to estrogen, but some of them also produces estrogen and create what we call a hypercoagulable state. And some of these hypercoagulable states often will create clots that affect the heart, right? So you can have a clot on the right side of the heart, which again causes a right heart failure. And here we go, leading on the likes of Dr. Atherley again. So we never take any of this for granted. And some of these patients, you know, it's not unusual for the first sign that they have significant fibroid is they show up with a deep vein thrombosis or blood clot in the leg for several reasons. One, the hormonal nature of this fibroid creates this hypercoagulable state and causes the blood to clot. The other thing is the size of the fibroids, the location of the fibroids, the orientation of the uterus can compress vessels in the pelvis or even the mid-abdomen and create venostasis or sluggish flow within the vein, causing a blood clot to develop. And oftentimes these clots can go to the heart, go to the lung, and they can cause, you know, what we call pulmonary emboli, which can cause sudden death. And, you know, sometimes they can go into the chambers of the heart and ultimately go to the head and cause a stroke. Now, typically this happens on the patients on the older end of the spectrum, but we occasionally do see clots forming in younger patients.
Excellent. I have a question. What about as far as genetics and passing it on to, you know, if mom has it, will the daughter sometime in her life be concerned that it's possible for her? What about that?
Yes. So, you know,
are you talking with respect to fibroids, or?
I'm sorry, go ahead, Doc.
Are you talking about genetics with respect to fibroids or GYN issues in general?
No, it was fibroids I was talking about, but yeah. Mm-hmm.
Yes, so there is some clear genetic association where there's deletion in chromosome 6, 7, 12, and there are a few others that I can't recall off the top of my head. And there are some specific deletions. And some of these deletions also are associated with other kind of cancers. So for example, there is one deletion that's also association with a renal cell carcinoma. So there's clear genetics involved, and it's not unusual for quote unquote conditions such as fibroids and endometriosis to quote unquote run in families.
All right, all right.
Now, if let me ask, thank you so much, Dr. Anderson. You've done such an amazing job with this. Now, one of the biggest issues that we often have, with, uterine fibroid and women in childbearing age is how often, if it does this prevent a female from getting pregnant or interfere with carrying on to the baby to term or even delivery?
Okay, and again, this is also an interesting topic that's far-reaching. Fibroids in of themselves often does not prevent conception. However, there are a few scenarios which one could imagine could. For example, not only can you have fibroids in the uterus itself, but you can also have a cervical myoma or a cervical fibroid, which intuitively can affect fluid and semen from passing through the mouth of the womb into the cervix. Depending on the location in the body of the cervix, it can be near or involve what we call the tubal ostia, which is the opening of the fallopian tube into the uterine cavity itself. So those are the major anatomic scenarios which I think can directly influence the ability to conceive. Now, one of the other ways they can affect fertility is the process of implantation. Okay, so if you have a submucous fibroid, one that protrudes into the cavity, if you can imagine an embryo trying to implant on a fibroid, that could affect the quality of the implantation, so to speak, and could potentially influence a miscarriage. Now, should a patient conceive and have good implantation and good growth, depending on, again, the location, the size of the fibroid, as the baby grows, the baby could essentially be compartmentalized, could be trapped in a certain portion or area of the uterine cavity, and can affect the ability of, one, the baby to grow, two, the rate of growth, three, and as you know, as pregnancy develops, the baby turns in order to get ready for delivery. It can have obstruction of the rotation and obstruction of the descent. Those are some of the more common ways that fibroids can affect a pregnancy. Now, as I mentioned before, pregnancy is also a hyperestrogenic state. And these fibroids do respond to estrogen or the level of estrogen. And what can happen is you can get rapid growth and degeneration and significant painful symptoms during the pregnancy. And that sometimes can often lead to preterm labor or premature contractions.
Excellent. I think you've covered this topic so well, and I thank you. If we have more questions that'll come through the question and answers, so we'll definitely answer those. But let me go on to some of the other questions that are coming through. All righty. The first one, it states, what can you tell me about a hernia surgery? Okay. I am scheduled to have growing and navel surgery next month. Can you help us out? Kevin, can you help us out with this?
Sure. So essentially what a hernia is, it's a weakness typically in the abdominal wall. And the most common areas are going to be the inguinal area, the groin area, and by the belly button. Congenitally, these are areas where you have weaknesses just from the development. The spermatic cord goes through it. The testes and the spermatic cord during development go from the abdomen into the scrotum, and you can have a natural area there that's weak. Now, in terms of the operation, basically the principles is just designed to fix that defect. So you could think of the hernia as a hole, and basically what you're doing is patching the hole. Typically, if it's a small hernia, sometimes you can do it, repair it primarily, which means you just bring the tissues together and suture it together. If it's a large hernia or more complicated, we typically use a piece of tissue called mesh, and that's designed to reinforce the surrounding tissues and prevent the hernia from coming back again.
Excellent, excellent. Yeah.
Kevin,
Go ahead, Patrick.
can you comment on some of the potential complication or side effect of doing a graft repair versus a suture repair, a primary suture repair?
So when you do a primary suture repair, typically, depending on how big the defect is, you may have what we call tension. If you have tension, then that's a setup for the hernia to come back again. So the reason to use mesh is to not only reinforce the tissue, but it's to prevent that tissue from being under tension. Now, the complication, because mesh is a foreign substance, you do get a reaction to it. You can get an infection, which it can become a huge undertaking if the mesh becomes infected, because now you have the tissue that's already weak, and now you have an infection that's going to create a bigger defect now, and potentially a bigger problem. The problem with hernias in general, especially inguinal, umbilical, and there's a term called ventral hernia, which is any hernia that's along the anterior abdominal wall, is the bowel can get trapped in it. And if the bowel gets trapped, you can get an obstruction, and that becomes a surgical emergency. So in addition to it being cosmetically not very appealing if you have a large hernia, there's serious potential side effects that can happen that are life-threatening. So the presence of a hernia should dictate that it should be taken care of. Now, just going back to a point that Dr. Atherley brought up, we typically match the treatment to the patient, not the patient to the treatment. So there's standard therapies for a whole host of things. Specifically cancer care, we have specific operations that are what we call standard. If a patient can tolerate the standard therapy, then that's always what we offer. But with certain limitations, if they're a cardiac cripple, then we certainly can't put them through a 5-6 hour operation. So those are the things that we look at, and not that we would give them substandard care, but we give them care that is effective considering their overall physiologic condition.
Okay, good. Kevin, can you explain to us mesh migration?
So, and this is typically in inguinal hernia repairs, is the mesh can move from the original location where it's fixed, and it typically migrates into the abdominal cavity itself. It usually happens when it's not fixated well. So if the sutures either break or don't hold, the location where the mesh it initially is put, which is in the defect, now migrates into the abdomen. Now it can also cause at that point a bowel obstruction, because it now can wrap around or cause adhesions in the small bowel. But it's usually in situations where it's a groin, the inguinal hernia repair.
Just right quick, Kevin, is there any non-surgical way of managing certain types of hernias, obviously based on size and so on, especially when we talk about patients who may not be good, quote unquote, surgical candidates, but have symptomatic hernias?
So there's abdominal binders that you can wear, and there's a device called a truss that you can wear for large inguinal hernias. It basically is supportive supportive devices. The issue is it doesn't prevent the risk of incarceration. It gives some symptomatic relief, but that risk again is still present.
All right. Kevin, can you explain incarcerated hernia?
Sorry. Oh yeah. So we defined a hernia as a defect or a hole. So through that hole, the contents of the abdomen, and specifically the most common organ that protrudes or comes out is the small intestine. When it comes out through that defect or that hole, if it gets stuck, it's called incarceration. If it gets stuck and it dies, it's called strangulation. And that's the main problem with having these hernias, is that if it becomes incarcerated or strangulated, it's a life-threatening problem which needs to be fixed immediately.
Right. Okay, excellent. We have quite a few other questions coming in. There's one question. Good day, everyone. And this is from CG. CG, thank you for sending this question. As the world is reopening and many are looking for quick fix diets, it says, do you recommend these fast diets, and why or why not? All right. I know that Patrick, you are always on the cutting edge of eating healthy, but I want to try this out a little bit. Maybe we can chime in with some of the internal medicine guys as well. A quick fix diet is usually anything that's quick fix is not the best for you. Understand? It's important to understand that when you're losing weight, you should lose weight at a certain rate. And we all have what we call a certain metabolic rate that we burn calories. Each of us burn calories at a different rate. Our thyroid is a gland that's in the base of our neck that determines how fast you will burn your calories. For instance, I may be able to eat 3 meals a day and maintain a normal weight, which would be my BMI, or basic metabolic index. But the thing of it is, there are other people that may eat 1 meal a day and they may not be able to burn those calories, and half of those calories are stored in fat cells, and over time they gain weight. So a fast food diet or a quick fix diet usually is unhealthy in a sense that what you're doing is you're actually starving yourself. You're not teaching yourself good ways to eat appropriate portions of food, number one, such that you can maintain the weight. Once weight is lost, you can maintain that weight loss. If you don't change the way you eat, how much you eat, choices that you eat, and get used to those choices, then as soon as you quick fix lose those 5, 10, 15, 20 pounds, you're going to go back to your usual way of eating. And guess what? You lose 10 pounds, you're going to gain 20 pounds back. And then you realize that you're overweight again, you're going to lose those 20 pounds, and then maybe you'll gain 30 pounds back. But over a year or two, you'll turn around and you'll understand that you may be 50 to 100 pounds heavier than when you even started the diet. So it's very important to understand that if you're going to go on a diet that has some boundaries, that you understand what you can eat, how much you should eat, a balanced diet so that you're getting appropriate proteins, carbohydrates, you're getting appropriate the vitamins, the nutrients that you need, such that each cell of your body can be healthy as you lose that weight. Patrick, you have anything to add to that, or Dr. Court?
No.
Well, if not, I would just add that it's important to bear in mind the rationale for the weight loss. While I understand that many people want weight loss for the cosmetic effect and obviously what it does to their appearance, I would, however, stress that there are several diseases which are worsened by excess weight. Now, from my viewpoint as a cardiologist, I'm very concerned about people who are overweight, in the sense that it not only predisposes them to get underlying disease, which can cause heart disease, but that having had the heart disease, it may increase the work done by the heart and potentiate heart failure. Of course, hypertension or high blood pressure is better controlled with people who are near to the optimal weight. And diabetes, of course, is another one of those concerns that we have. So it is very important to look at what underlying diseases may be worsened or may occur more significantly in patients who are overweight, and especially those who are grossly overweight.
I also think one of the things, pursuant to what Dr. Atherley just said, is you need to define your goals, and whether you lose weight for appearance or lose weight to enhance function. And when we go on these diets, we need to pay attention to the goals. If the goals are to gain muscle and lose fat, then we need to understand the components of a diet and understand that what's necessary to gain the advantage in the different areas. So if we want to gain muscle to improve function, you may want to pay attention to your proteins and the type of amino acids within the specific proteins that you're consuming, or versus if you want to just lose fat, and this is in general is true across the board, look at the amount of carbs that's on your plate. Now, if the mechanism that you use to complement the diet is increased activity, now you may not want to, drastically reduce your carbs because, that ultimately will become sugar, which is required for energy. And you want to maintain the protein component because when you have vigorous activities, you get micro tears, micro fractures in muscles, and you need those proteins for repairing the bones, supporting the joints and repairing the muscles. Another component is the micronutrients, the substrate that goes into those proteins to cell metabolism, right? So oftentimes people who go on diet becomes lethargic, and they say, well, it's because I'm not taking enough energy. But it's the micronutrient. The equivalent of that is you're not just put gasoline in your car, but you may want to pour some additive into to improve the octane, right? Or you may want to change the filter so more oxygen goes into the motor, and that's essential. So we have to also pay attention to the micronutrients as well.
Excellent, excellent.
I think in general in medicine, I think the comment was a quick fix diet. There's nothing good that's a quick fix usually.
Right.
And not to say that it has to be complicated, but it has to be well thought out, and that probably is not a quick fix.
Yeah, and the thing of it is also there are certain medications, like, in the past you used to think of certain medications that are prescribed, like speed, that revs up your metabolic rate. And as that metabolic rate I was talking about, and once you come off those medications, then, your metabolic rate will decrease again, and that weight will just come back. Also, the things like fast food restaurants or things and what you eat. I look at the fast food restaurants and I'm saying, some of the meals, true, they're not that bad, but when you are able to offer a meal at such a cheap price, there has to be some cutting of I should say nutrients possibly, or necessary ingredients that you need to be healthy. I know that there is a chance to increase your weight with some of the fast food restaurants if you eat that type of those type of meals too frequently. So it should be a balanced meal. It should be, and you understand, I think, Patrick, you stated this, that you cut your portions in half, meaning that you cut your portions of high sugar in half, you cut your portions of carbohydrates, things like bread and pasta, potatoes, cut those in half. We each know how we like to fix our plate. Everyone, as an African American or a person of African descent, you know how you like to fix your plate. And when you fix your plate, you know how much carbs you want to put on your plate. Just cut it in half. Just take 1/2 of what you normally take. And as far as your vegetables are concerned, you increase it by 1/2. Increase your salads. And if you note this, that if you decrease your salt, your sugars, your carbs, you're still eating what you love, but now you're cutting your calories down. And that way you don't feel deprived, and you can maintain that way of eating for the rest of your life, because your metabolic rate is not going to change. So you have to change what you can do, that you can maintain this. And I think that's a healthy way to do it. A healthy weight loss also is about 1 to 2 pounds per week. So you really want to stay within that parameter if you can. That's for sure. Anybody else has anything?
But I just also think, Omar, that, quick fix, when we use terms like quick fix, it speaks to that immediate gratification of losing the weight. And sometimes in order to be effective, you have to stand in front of the mirror and ask yourself, who am I? When I'm talking about quick fix, am I someone who's seriously invested in something, right? And a serious investor in weight loss should understand that it's not just about the food you eat, how much of it, when, and the what, but also the physical activity. It's a broader conversation, because as a part of weight loss is in improving body function efficiency, and anything you can do to improve oxygen consumption will also enhance caloric loss through activity. So it's not just about the diet alone, it's diet in conjunction with physical activity, and to do it in a safe way.
Right.
Let me just add, though, that the objection to the word quick fix is not always a bad thing.
Right.
And from my viewpoint, quick fix is extremely important and encouraged in the setting of an acute heart attack. Understand, when a heart attack occurs, there is a total blockage of a vital artery to the heart, causing death. Maybe not too slow death, but a death within hours of not the whole body necessarily, but of the heart muscle. And if the heart muscle dies, it can never be made to function adequately as before. So in the setting of a heart attack, I would like our listeners to be aware of a heart attack when it is occurring and attempt a quick fix, because if we get you into the hospital and into the lab, one of the things that I tend to do a lot of is when a certain kind of heart attack occurs, we get you into the laboratory, we pass tubes into the heart, into the arteries, and we get rid of the blockage that is occurring in that artery. And if you can do it quickly enough, we can fix the heart in a sense so that you do not suffer the ravages of a major heart attack. So there are some times when a quick fix is vitally important in preserving your health. Okay.
All right. Well, since you went down that route, I want to ask you. I'm at home and I think I'm having a heart attack. What are some of the quick things that I can do to help myself besides calling 911?
Yes.
I totally concur with Dr. Atherley there. In the world of cardiology, it is said time is muscle, right?
That's right.
Is muscle. The longer you wait, the more muscle dies. So yeah, in this case, quick fix is important.
I have a question, Dr. Atherley. Dr. Patrick, Patrick he stated something. What are the things that someone can do at home? Give me an idea whether aspirin, immediate aspirin, does it help? Because we need to know that as a general public.
Okay, fair enough. I think the thing that is most important for you is to recognize that something serious may be happening. And that is a recognition of the signs and symptoms of a heart attack occurring. When you do this, then you take immediate steps. First of all, then the signs and symptoms of a heart attack occurring are the most classical is a severe pressure-like squeezing pain in what we call the retrosternal area. That is in the center of the chest. Well, many of us tend to think of the heart as a left-sided organ. It is in fact a midline and somewhat leftward organ. Essentially, however, in the classical setting of a heart attack, there's a severe crushing pain, which may not be related to exertion or activity, as happens with angina or the lesser form. This may suddenly hit you for whatever reason. When this occurs, it is often associated with what we call diaphoresis or profuse sweating, a cold sweat. You may be short of breath or dizzy. You may feel as though you want to faint. When these occur, you should seek help immediately. But before the help can come, you may do something which can help you yourself in the event that you are truly having a heart attack. As I mentioned, a heart attack occurs when there's a blockage of those vital arteries to the heart. The blockage is usually occurs, if I go into a little bit of the background, fatty deposits in the walls of these arteries can gradually narrow the arteries. And this can give rise to what we call anginal pains. These are pains like a lesser form of heart attack, but occur precipitated by exertion, stress, etc. In the setting of a heart attack, however, a sudden event occurs, and this very often is actual rupture of a plaque, that is, a rupture of one of these areas of the artery, which is laden with cholesterol deposits. So this suddenly ruptures and releases certain chemicals into the bloodstream, which trigger the onset of the heart attack. And one of the earliest consequences is the clumping together of tiny components of the blood called platelets. So when you take the aspirin, you're not taking it because of pain. A single aspirin, a baby aspirin, an aspirin quickly chewed, it may be life-saving, but it may be because it helps in preventing the clumping together of these platelets, which then totally block the artery, lead on to further development of blockages from other components of the bloodstream. So this very early effect can limit the blockage and give you a little more time to get to the hospital and to have proper treatment to take care of that blockage that's developing.
Excellent.
One quick question. Does it matter if it's a baby aspirin or 325?
Not really. I mean, a baby aspirin will suffice. What matters is how quickly you get it in. So we suggest chewing it so that it is absorbed from under the skin, as opposed to going all the way into the stomach and getting into the bloodstream by that route, etc. Chew the aspirin, chew it quickly.
Right.
And then, of course, seek help.
Right.
Yes.
But before that, I think it's important to understand that, look, a plaque or those narrowing on the heart does not start or begin in a day. It takes months or even years to occur. And by the time you have, factors, precipitating factors like high cholesterol, diabetes, high blood pressure, obesity, all of those things are risk factors that can predispose you to developing a heart attack. So if you have any of those, please see your doctor early enough and get treatment. I have a treatment plan that's tailored to you to help you. But my question to Dr. Atali, now, is there any physical maneuver that somebody with impending heart attack or heart attack in evolution can do before, the help really comes, other than taking the aspirin, like maybe squatting to reduce the cardiac output or increase perfusion, any of those things that often enough to do with congenital heart diseases?
They may be of limited value and under specific circumstances. It is felt that if the heart manifests certain arrhythmias or irregular heartbeats, where in addition to not getting its own blood supply, it doesn't pump blood well enough to the other parts of the body. Certain severe arrhythmias, that coughing may help in improving the blood flow to these vital areas. That's of limited benefit, and it may help. However, you may require help by bystanders or others who may be called upon to perform CPR. Because again, one of the consequences of having a heart attack is that the heart may fail entirely as an organ, not pump blood properly, and you will require someone to perform resuscitation on you with compressions of the chest wall to push blood through other parts of the body, especially to the vital organs like the brain. But I will say, Nelson, that you did make a very important point in terms of the long-term effects of these diagnoses that you've mentioned, high blood pressure, and a few others that we consider risk factors. Be aware of the risk factors yourself and control them. Control your high blood pressure, control your cholesterol, especially the bad cholesterol or the LDL cholesterol. Control diabetes. There are some things that you cannot control, of course. If you have a family history where other members of your family have had heart attacks at young ages, be aware of the potential risk that you may face, but recognize that there's nothing you can do about them. The male sex, of course, males are troubled by lots of things compared to females, not the least of which is that we are predisposed to having heart attacks at an earlier age than females. They're somewhat protected up until the area of the menopause. So there are things that you can do. And the point about the long-term development of these has been exemplified. I'll give you one example here. The post-mortem studies performed on otherwise healthy soldiers in the Vietnam War and then later wars. Postmortem studies show that in young, apparently healthy males, there were already signs of early development of atherosclerosis or deposition of fat in some of the arteries of these patients, totally undiagnosed. So it just shows that this may go on for decades. But then when it reaches a critical stage, when that blockage reaches a critical stage, then there may be a sudden acceleration of findings, symptoms, and consequences. So long-term effect, long-term benefit in taking care of your health. And of course, I didn't mention the rather obvious one, which is exercise, proper activities, and diet.
Right.
Trevor.
Sorry, 1 minute. Dr. Adley, since we're still on that and the early development of atherosclerosis in young people, now we live in a world where, you know, everybody wants to go natural and take all things natural.
Well, I'm sorry, wants to do what?
I said everybody wants to take everything natural.
Oh, okay.
So, and there's a huge play right now in the society that other things can help your heart. But one of the ones we see on TV so often enough, and I've talked about, is omega-3. What's the role of omega-3 fatty fish oil in reducing the risk of plaque formation and atherosclerosis?
It's a somewhat of a controversial aspect. I'm sure you may have a different impression. Many of us may have our own individual impressions based partly upon the science that's available. However, I will say that not harmful. I'm not sure that there is tremendous benefit to the omega-3 taking those artificial means. I think that part and parcel of a properly balanced diet, looking at the cholesterol in your diet, is important. There are many studies, however, which have shown that natural foodstuffs which contain high levels of the omega-3 fatty acids, for example, fish from cold water, tuna, salmon, etc., that these are helpful. However, the extent to which omega-3 fatty acid tablets, etc., are helpful is questionable, but it may, of course, be of some benefit. So I certainly would agree, not harmful and maybe helpful.
My question is for both Dr. Atherley and Dr. Bain. Some months ago, I received something on my phone in terms of a male driving along the road, and he has symptoms of a heart attack. And the recommendation was that if you breathe a certain way, this would trigger your heart to pump as if it is pumping normally. Have you ever been told of this or have any comments on that?
Oh, from my standpoint, from a pulmonologist standpoint, I've never heard that if you breathe a certain way. I know as far as patients that have respiratory insufficiency, meaning that their ability to breathe and get oxygen into their lungs, if you take large breaths, and I could only think in a sense that if you took large breaths, you're getting more oxygen to the bloodstream. But I'm not sure if that would affect what they're stating. I just don't, I have no knowledge of that, Dr. Court. Dr. Atherley, can you help?
Were they suggesting long-term or short-term immediate benefit in a specific acute situation?
Short-term, because the heart sits on the diaphragm. It simulates movement of the heart as if it's contracting the same way.
From the diaphragm? I understand what you mean. And when we take a large breath, you have diaphragmatic excursion. And what that means is that in order to breathe, your diaphragm has to push down into your abdomen when you're taking a large breath. And your ribs actually, the muscles of the ribs actually contract and come together, and your rib cage expands out as the muscles contract. And your diaphragm pushes down such that your lungs can open up and take a larger volume of air. Now, whether that actually pushes on the heart or gives the heart more contractility, I've never heard that. I just don't know that.
I think that comes out of the play, of a physiological play. If you look at what's happening with the heart and the diaphragm as it expands. So when the diaphragm goes down, the lungs expand and more air comes in. It creates a negative pressure within the cavity. So it is said in physiological stance, there's an increased reduction, response and backflow into the heart. That's just basically what it is. But people
Yeah.
run away with those kind of things and say, oh, it really does, improve your cardiac output.
Yeah,
So
well,
It was one of those internet things.
yes,
yeah, yeah, because if you understand the function of the lung actually is in a negative. It's in a negative force there, and when you take a deep breath, you increase the negativity of that. Of the pleura, so I can understand, but the heart sits in a cavity where I really don't think inside that cavity it's affected by the lung negativity.
There's some old story on physiology of that. That's what people run away with, those kind of stuff, and they just want to make a big deal out of it. That's what it is.
All right, all right. Well, I think this is a perfect time to take our break. We're a little bit over, and I see that Dr. Salam has joined us, and I'm so glad he's come in. I know that he had a hectic day at the office or at the hospital, rather, and we're so fortunate to have him come. Definitely. So let me take this moment to give us our second half announcements. Okay, and what I'd like to do is just because I know that people have joined and missed the initial introduction. So let us do this. Let us start with an introduction of each and every one of us, and then we'll go on and we'll answer some more questions. Dr. Atherley, can you please start it off, please?
My name is Trevor Atherley. I'm an interventional cardiologist, primarily based in Essex County out of Newark Beth Israel Medical Center. There I am an attending cardiologist, and one of my major interests is, of course, in being a part of the teaching force there.
All right, excellent. Thank you very much. Dr. Court.
Dr. James Court, internal medicine. I just treat adults. Internal.
Okay, and Dr. Patrick Anderson, please.
Hi, I'm Patrick Anderson. I'm a GYN cancer specialist. I do practice some general gynecology and take care of some maintenance issues. I practice with most of these gentlemen here out of Newark, primarily out of Newark Beth Israel Medical Center. Glad to be here. Excellent.
Dr. Aluya.
Well, Nelson Aluya, medicine and pediatrics trained, a medical advocate, assistant professor of medicine, and attending at Newark Beth Israel Medical Center. A wonderful contributor to this panel. Thank you.
Excellent. Dr. Kevin Clark.
Dr. Kevin Clark, surgical oncologist. I work at Newark Beth Israel with most of these gentlemen here. Glad to be here.
All righty. And Dr. Kareem Salam. Thank you. Welcome.
Glad to be here. Dr. Kareem Salam, board certified adult child and adolescent psychiatrist, working in the city of brotherly love and sisterly affection known as Philadelphia, on the faculty of Drexel University College of Medicine and founding member of Global Health Psychiatry. Delighted to be a part of this webinar.
All righty. And I would like to say that, thank you. Oh, I always forget to introduce myself. I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a subspecialty in nutrition, and I am overwhelmed by I should say, the amount of knowledge on this webinar, and so proud to be here with all of these great physicians. Take heed. This webinar is every second Saturday at 1 o'clock. We are here, and you just have to go to OBHealthy, and on the bridge of OBHealthy, you will see Physicians Network. Just click that, and you can register into the webinar and type in your medical questions. So we are looking so forward to answering your questions. The most important thing that I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor best knows how to treat your medical problems. I would like to thank OBHealthy for allowing us to use their platform, and it's just so great to have all of the participants out there listening to the great words of all of these physicians, because health is so important to all of us. All righty. So as far as I have some more questions, and they're definitely coming in here. There was one question. It says, oh, hold on. I read that one already. Let's go to another one. All righty. And a lot of eating questions. How about that? Here's another one. Eating healthy and maintaining a good diet can be expensive. That is true. Not all of us can afford the plants to plant our own foods and buy organic on a consistent basis? What can we do to eat as best? Oops, hold on. Too many questions are coming in. It jumped out of my.
Okay.
I'm sorry. It jumped away from me. All righty. I'm not sure. Maybe somebody was getting ready to answer that question and it jumped out.
Yeah, Omar, I typed an answer.
All right. As soon as you clicked, it jumped away from me. Okay, I got it back. I have it back. What can we do to eat the best as possible? High fructose corn syrup is a preferred example of something to avoid, but it's almost always it's in almost all of our foods. Patrick, if you've already started the answer, why don't you tell the rest of us some of the things that you're thinking?
Well, what I'm thinking is, if you're a consumer, you know, the general approach ought to be to stay away from foods that are highly processed. You know, most suppliers now have a chain or a good set of quote unquote organic products, if that's what you're looking for. And what does organic means? You know, how it's grown, how the seeds are raised, and those kind of things. But you know, when we start to mention the component within foods, that's when, you know, you start to think that what's being talked about is processed foods. And you know, early on in one of these symposium, we talk about when you shop, where do you shop? You shop on the outside of the supermarket and stay outside of the outer aisles and stay out of the middle aisles, because the middle aisles, that's where the processed foods are. Now, what I can tell you, and this is from my own personal experience with a little bit of investment in time and a even smaller investment in equipment, for a small family of two, you can virtually grow all your vegetable needs in your basement under a light through some, you know, a little bit of ingenuity. And it's incredibly therapeutic, because I can tell you, when your wife don't want to talk to you, go talk to your plants. And then you bring them to the table and she'll be smiling at you. Like, you know, we've grown, you know, tomatoes in our basement. We've grown lettuce that we just take from the basement to the table in the pot, and you pick it and you just spray wash it and you use it and put it right back, and it grows some more. Because many of these, you know, shallow root plants are self-propagative. You know, if you harvest them correctly, they just keep growing and growing and growing. And those are your basic greens like spinach and lettuce and kale. I've grown beets and carrots under lights, you know. So if you have even a fairly medium-sized kitchen counter next to a window, it's amazing what you can grow. Herbs, spices, you know, some heirloom tomatoes, obviously small species tomatoes, lettuce, spinach. I mean, even onions you can grow. So, you know, and then the other thing is, utilizing co-ops, you know, seek out family members who have the same intent and create a co-op and take turns going to specific markets and buying for everybody and delivering. We also find that before we were able to grow our own food, you know, that utilizing that approach was also beneficial.
Yeah, excellent, Doctor. You know, the thing of it is that, and it's a problem in our communities. Number one, some communities are food deserts in a sense that we don't have appropriate, you know, grocery stores or supermarkets that we can go to. We have to go to the local bodega. And usually the food is not as fresh, number one, and more expensive in those small stores. So what you suggested, you know, a co-op, get friends and family together and go put your money together and buy and then split it. You can save money and buy more for less money that way. But it's very difficult in our communities, more difficult in our communities to eat proper, because, you know, fast food restaurants are too available. And sometimes you come home and you're tired, and the first thing you're going to say is, you know, I just don't feel it's easy to go down the street to get a fast food.
And let's face it, the fast food restaurant, just remember, their whole platform is, Dr. Salam can help me out here, is based on intrinsically what we know to be addictive, right? And there's been studies to prove this, that, the salt, the sugars, the colors, and that we put in some of these meals that are then marketed as low price for more. And be careful, low price or more also encourages you to consume more calories than you really need. So, it becomes a real play on the psyche, how to utilize fast food restaurants.
Dr. Salam, can you chime in?
Absolutely. So, and please give me a double thumbs up if you can hear me. I'm technologically challenged at this point. But as Dr. Anderson so aptly mentioned, in certain neighborhoods, and I believe Dr. Bay as well, there's certain neighborhoods that are food deserts. So there's a dearth of freshly grown, whole foods available in those neighborhoods. And there's a surplus of fast food franchises that sell cheap, calorie-dense foods that are awash in things like high fructose corn syrups, various additives. And the human brain has a powerful fondness and affinity for sugary foods, fatty foods. And then these things could be prepared with great convenience under the mask of affordability. And those of us who are on this call now who focus on metabolic conditions and cardiology could discuss the impacts that these calorie-dense, inexpensive foods have on the physiology. Moreover, they could very well be addictive, and they could be reinforcing, because in addition to tasting good, they make us feel good, hence the name comfort foods. So we take comfort in these unhealthy foods, and if they dominate our diets, they could have pretty significant health conditions and place us at risk for chronic metabolic conditions, whether it be hyperlipidemia, diabetes mellitus, and those are conditions that affect the blood vessels and anywhere in the body where there's blood. And so I've yet to discover the place on the body where there's no blood. So they affect every organ system in a powerfully negative way. And so if you can't give them up entirely, you should certainly limit your intake, or at least balance them with fresh foods. Excellent. And water, the importance of water, critically important. The best beverage at the best price, free.
That's true. That's true. All righty. And let's go on with a couple more of these questions here. Dr. Anderson, there was a question that came in, and you may have answered this on your typing. What type of medications is usually used to treat fibroids?
Yeah, I think I thought I answered that one as well. So there, the medications that typically are most effective in treating fibroids are usually medications that are anti-hormonal or anti-estrogenic in nature. One of the main ones that's used, and it's used for multiple conditions, it's one of the we call the gonadotropin inhibitors. Gonadotropins are hormones that are secreted from the pituitary and ultimately stimulate an end organ, such as the ovary, to produce or mature an egg. And during the process, you get various levels of estrogen and progesterone. And some of these hormones inhibit that whole axis on the pituitary level. And that's Lupron is one of those medications. Now, sometimes some physicians may add, depending on the circumstance, things like birth control pills. And what that does is they try to regulate the menstrual component of the bleeding and ultimately decrease bleeding. So medications like Lupron will shrink the fibroid. Unfortunately, it has other confounding problems in that it can also affect the bones with long-term use. So it's recommended that if you have to go beyond a certain time period, usually 6 months, that you add back some of the same hormone which you're trying to limit in order to help prevent things like osteopenia. So that's one of those are some of the main ones that are used.
Medications. Excellent, excellent. Dr. Atherley, there was a question that came through. Do statins contribute to diabetes? This is from DY. Thank you, DY, for sending this a quick question in.
Yes, it's a very important question. I think several years ago, there were a few studies which documented an increase in diabetes noticed in people who were taking statins. That has subsequently been pursued. And while there is no doubt that taking statins over a prolonged period of time, that is more than 2 years, especially in high doses, may precipitate diabetes in those who are predisposed to it. That is, those who have the multiple risk factors that can give rise to diabetes. The absolute occurrence of diabetes is still quite low. Now, the American Heart Association came out with a statement addressing the concept of statins and diabetes. While we acknowledge that statins may precipitate diabetes, the absolute risk is less than 0.2%, 200,000. So clearly it is not a major risk. Furthermore, the absolute benefit of taking statins where there is a clear indication to so do implies great benefit of statins. So I would not at all hesitate and do not hesitate in recommending statins. This is commonly used medication to lower cholesterol. I would not hesitate in using that for the fear of inducing diabetes. It is a true but very, very small risk and is certainly far outweighed by the benefit, life-saving benefit of taking statins. So I'd like to dispel that.
Oh, excellent, excellent. There's another question. Patrick, you're going to have a lot of questions here. There's another question that came in, and we may have answered this. Dr. Anderson, and this is from P. I'll just giving the initials of people who are sending their questions in. This is from PE. Thank you, PE, for sending this question in. Dr. Anderson, won't the extra estrogen from the pill cause fibroids to grow more or cause a higher risk of blood clotting, or DVT, or that's deep vein thrombosis, which is clots in the lower legs, for those who don't know that what a DVT is. That was earlier mentioned.
I actually just let in and answer that question. Typically, the level of serum estrogen from the pill is actually lower than what's produced by the ovaries. But essentially what the pills does, it tricks the body into thinking it's pregnant, so you don't ovulate. And as a result, decreases the amount of estrogen produced by the ovaries.
Mm-hmm. Okay, excellent. There was a question, Dr. Court and Dr. Aluya. There's a question coming in. Why do you lose feeling in your feet with diabetes?
All right, well, Dr. Court wants to take on that?
You're going to start it off, Dr. Court?
It's because of having diabetes for a long time. It affects the peripheral nerve. And as a result of that, patients can have loss of sensation in the feet.
Mm-hmm. All right. Yeah. All righty. Dr. Aluya, you want to expand?
Yes. So a lot of all this came about when we started, delineating the different types of diabetes. Diabetes itself and the different types. And then there's an entity called pre-diabetes, meaning you don't have the signs and symptoms of diabetes yet, but if you check your A1C, which I've always advocated that everybody on this platform should know what your A1 status is, A1C status, which is the hemoglobin component that the glucose that's attached to, because the essence is this: the red blood cell, which is the one that carries oxygen all through your body, lasts for about 3 months. So they found a way to measure the amount of glucose that red blood cell carries all through its lifetime for 3 months. So we can basically tell what your sugar status would look like in the last 3 months. Now, coming down to the question for the day is, once you begin to develop increasing insulin resistance, meaning the ability of the body to utilize insulin for glucose breakdown or metabolism, then the amount your A1C begins to creep up. Now, ideally, the number should be 5.7 or less, meaning you have no diabetes without symptoms. Now, 5.7 to about 6.9 is considered about pre-diabetes, of which in this country right now, there are about 88 to 90 million people who are pre-diabetic, and in the next 4 to 5 years will become diabetic. So that's why it's so important to know what your diabetes status is. Now, what's the significance of that? Because those minute changes begin to take place once you get to that level where you're pre-diabetic. Now, before we used to think, oh, once you become diabetic and you have symptoms, that's when the disease begins. No, it actually begins 4 to 5 years before you truly begin to have symptoms. That's why it's so important. Now, those changes take place in the tiny, tiny vessels within the brain, tiny vessels within the kidneys, tiny vessels within the eye. So it's in the brain, it risk of stroke. In the eye, it causes retinopathy, meaning changes, blurring of vision and all that. Within the heart, within the kidneys, where you start spilling protein in the urine, and then within the leg, where you have burning sensation. Now, we need to remember that the nerves themselves have blood supply, because for the nerve to leave, they have to have its own blood supply. And those blood supplies are called vasa nervorum, vasa nervorum nerve. So because they're so tiny, and the blood vessels are even so tiny, so those changes, those plaque, those blockages that begin to take place before you actually begin to have signs and symptoms take place early in those tiny blood vessels. So they begin to show effects because it's in the nerve. So the nerve will quickly respond and begin to have changes, burning, fireflies or insects crawling up and down your legs. Those also within other signs and symptoms are early signs and symptoms of diabetes. So that's the reason why the tiny blockages within the tiny blood vessels that supply the nerves, they begin to get damaged, and the nerve begin to get damaged itself. Then you see those signs and symptoms.
Yeah. Excellent. All righty. The thing of it is, and I'll also say, some of the things that really I see as patients in the ICU and in the hospital is that for African Americans, the amount of lower extremity or leg or feet or toe amputations secondary to diabetes is significant. I think it's the number one cause for amputation in African American is diabetes. And that's because those small blood vessels are affected by high glucose, continued exposure to the high glucose over time, and their dysfunction and their inability to get appropriate blood to those extremities, because the feet are the furthest thing from the heart. And of course, it's going to be difficult to get that blood down there, and it has significant changes on that, such that they require amputation if it gets really bad. That's just one aspect. Dr. Salam, please.
Yeah, Omar, you mentioned earlier, you explained what a deep vein thrombosis was. It might be worth mentioning the connection between that and a pulmonary embolism. That might be for the audience to understand.
Yeah. Let me just explain what a deep vein thrombosis is, because I went very quickly with that. What it is you develop a clot in the deep veins of the legs. And usually it occurs in the thigh area, but it can extend down to the calf or extend up into the pelvis. It always doesn't have to be in the thigh itself. It can be in the pelvis, and the legs don't have to be directly involved. Usually there's some swelling in the lower extremities or the legs, and usually there is pain. It's called the Homan sign. If you pull the toes back, pull your toes up, and if your calves hurt, then that is the Homan sign, saying that there's a likelihood that there could be a clot there in the lower extremities. This clot can form for many reasons, actually. There are many reasons that we as docs call it hypercoagulable state. What that means is that your blood clots unusually quick or for unusual reasons. And usually a clot will form if we cut ourselves. The reason the reason we stop bleeding is because a clot forms. And clots should not form in your blood vessel unless there's a reason for it to clot. But for some reason, it can be many reasons. Cancer can cause blood vessels to clot abnormally. And the most frequent reason we find is that for some reason we're inactive. Patients that are laying in bed for a long time, especially in the hospital, the first thing we do is we give them a blood thinner, because we know to keep your blood flowing, you need activity. You need to be walking. You need to be standing up. If you're laying in bed all the time, the chance of clotting increases dramatically. Also, when you're, for instance, a classic example, I always tell my patients this, is that muscular, strong guy sitting in an airplane for 2 or 3 hours and flying. And this guy gets up and walks out of the plane and then faints in the airport. It's because that he had a clot develop in his lower extremities because his knees were bent for about 3 or 4 hours, and the blood flow wasn't able to travel appropriately, and it slowed up and a clot formed. Now, as far as Dr. Salam, you had mentioned a pulmonary embolus. And what is a pulmonary embolus? And I think we had mentioned this briefly talking when Dr. Anderson was talking. A pulmonary embolus is when a clot in the blood vessel of the lung, a clot forms or travels up to the blood vessel in the lung area. So let me explain this. Deep vein thrombosis, it's not in the arteries, it's in the veins of the body. Okay, the veins of the body. And the veins, they are bringing blood, those veins are bringing blood back to the heart. All righty. Arteries take oxygenated blood that has grabbed oxygen and lead it out from the heart into the blood, into the body. But veins are bringing that blood that has given up its oxygen back to the heart. And once it gets to the heart, then it goes through the heart, the right side of the heart, and then it goes into the lungs to grab oxygen. Well, what happens is the veins of the legs are where these clots form. If a piece of that clot flicks off, it will travel through the vein and go up through the right side of the heart, go into the lung. But when it gets into the lung, those lung vessels get narrow and narrow and narrow, so that piece of clot get wedged into the blood vessel, so there's no blood going forward. And that's what a pulmonary embolus is. And when you have no blood going forward through the lungs, that means that blood that's supposed to go from the lungs into the left side of the heart is decreased. And that means the amount of oxygen going to the body is decreased. That means we have a serious problem. So that's basically how a DVT or a deep venous thrombosis becomes very, very critical. When a piece flicks off and goes up to the lung, it can cause, severe medical problems or even death. Thanks for answering that question, Dr. Salam.
Right. So, Dr. Bey, I mean, just to, I know you talked about it, but to draw a little focus on it, especially now that the COVID era is going away and it's summer and we're opening up the economy and opening up everything. A lot of people will be traveling. So one of the things I often see at this time as well is DVT and PEs, like you just said. So please, and I've written every summer about this, especially for those who do long travels, long international or intercontinental travels, especially those who do one-stop flight. If you're flying from here to Nigeria, to Ghana, to, Accra or wherever, and you take that one-stop, non-stop flight, you sit all through, you form a risk of developing clots in your legs. And those clots may build up over time and may not dislodge until you get home. I've had issues where people get home and the first thing they're trying to get out, unpack, and they fall down and die. Or when they come back to the US, these are the things, but eventually a lot of them end up in the hospital. We also have those who travel from here to North Carolina, South and Florida, and especially if you're over 65 years of age with risk of chronic medical condition, and they also have a risk. So the advice I tend to give them, please, when you do, every 4 to 5 hours, stand, stretch, and do stuff. But otherwise, if you're really prone, take a baby aspirin a day before you leave, on the day you travel, and the day when you get there. And do the same when you're coming back as well. It really does help, and it has often helped mitigate those problems.
Omar,
Excellent.
Omar, we shouldn't forget that there are other causes of DVTs, conditions that you inherit from your parents or grandparents, like the protein C and protein S deficiency and lupus anticoagulant and MTHFR variant, another thing. So in addition to looking at whether or not you've been immobile, you should also consult with a hematologist in case other causes of the DVT has not been diagnosed.
True, true. If you have a family history, or if you have several people in your family have had blood clots, or if you have had one blood clot and had a second blood clot, you should definitely be worked up by a specialist called a hematologist, which is a blood specialist. Because in order for our blood to clot, there is a chain of reactions that has to happen. A multitude of chain reactions have to happen for proper clotting. And you can just have one abnormal factor out of that chain to be occurring to have you have increased ability for clotting to occur in your body. So definitely you should be worked up by a hematologist or a blood specialist. Anyone else have anything to say on this? Because this covers so many realms as far as medicine is concerned. Dr. Salam.
And is it true that DVTs are more common in women who are on oral contraceptives and in those who smoke cigarettes?
Yeah, I'm gonna let Dr. Anderson answer that one, but I think it's going to be yes. Patrick, can you expand on it some?
I think, the current oral contraception that we have, the low dose pill, the incidence of DVTs are much lower than when these higher dose pills hit the market many, many years ago. And the issue with smoking is the physiology behind it, I'm not clear on, but apparently in smokers, there's also a higher circulation of estrogen in the blood, which can be a predisposing factor as well.
Yeah, I know from the arterial side, with smoking, obviously it increases the possibility of hardening of the arteries. And you definitely get but those effects are more of what we were talking about, similar to diabetes, where you don't get proper blood supply to the lower extremities, and you get necrosis or gangrene of the toes, or amputation, or you get the ulcerations of the foot and the toes that are very hard to heal because you're not getting appropriate blood supply there, and that can happen secondary to smoking. That's for sure.
With regards to the smoking, we talked about what they call epigenetics here before. Epigenetics is just basically how your DNA is, the expression of your DNA is changed. It doesn't change the DNA component itself, but how the DNA is expressed. Environmental factors will do that. Radiation, altitude, the food you eat, and everything else. So also is smoking. So with that respect, we begin to know now that tobacco actually increases, just like the epigenetics issues, increases the polymerization of certain DNA components. There's some DNA, MOCK1 and all those stuff that it actually changes by polymerization of those DNA as it expresses, that increases platelets aggregation. That's the platelets coming together. So, and if you have a combination of someone who smokes, who's obese, and then of course, on tablets or medication that can increase coagulation, that's a perfect storm for that to happen.
All righty. We seem to have lost Dr. Salam. I had a question for him. Hopefully he will come back in as far as
I'm here.
All righty, Dr. Salam. I know that you take care of teenagers and everything. Give me and this question came in some time ago, but I definitely want to ask it. And thank JM for asking this question. Why has suicide increased in Black kids with COVID crisis?
Oh, excellent question. But just to take a step back, suicide rates had increased in African-American children actually pre-COVID. And COVID just has really exacerbated underlying problems that have been present for a while, and COVID has put them in stark relief. So just a number of things have affected the psyche of African-American children, especially both males and females, with the advent of media and the rash of young people who have been killed by law enforcement. People like Trayvon Martin come to mind, Tamir Rice, Breonna Taylor. Many youngsters have a sense of a foreshortened future, and they feel that their lives are not valued. So if the world doesn't care about me, why might I care about myself? Moreover, the havoc that COVID has wrought in terms of diagnoses, hospitalizations, case rates, and death rates. So folks have seen a tremendous amount of loss. But in addition to that, COVID has impacted finances with our community in a disproportionate way. And that affects the most vulnerable in our community, our dependents, like young people. But, so those are some of the factors that have contributed to increased suicide rates amongst young people. This has been such an important problem that's brought to life. I believe it's a congresswoman from New Jersey. I think it's Bonnie Watson Coleman, who's part of the Congressional Black Caucus, who spearheaded a task force to address suicide rates amongst African-American youth. And I know that's an important effort through the Boris L. Henson Foundation, established by the actress Taraji P. Henson. So this is certainly a challenging problem. And I didn't even get into the realm of stigma and the impact that has had on our community. Stigma as it applies to drug and alcohol treatment, and more specifically, mental health treatment. So we come from a community where we've had to be very resilient historically. And so that sometimes impedes folks' ability to be vulnerable and participate in mental health treatment like therapy or the like. So I encourage folks to really keep an eye on their youngsters. I tell people I'm an expert in child and adolescent psychiatry, but you're an expert in your niece, your nephew, your son, or your daughter. And don't talk yourself out of seeing things that you actually observe. So if your cellist is no longer interested in cello, your basketball player has lost interest in their athletic pursuits, your scholar has lost interest in their academic pursuits, and they have a decline in their functioning, you really need to explore that and encourage them to get help. Don't unsee what you actually see. And it's critically important to check in with these young people before they make decisions that have consequences that can't be reversed.
Excellent answer.
Let me ask a question to that. I know, Dr. Salam, we've talked about here before that during the COVID, this is not the time to take away, your social media as a means of punishment to your younger ones. Nevertheless, in breaking down those studies, 2.5% increase in suicide among young African Americans. Now, I would love to see a little breakdown. Is that number higher in men or women? What are the active or intentional means by which this suicide is committed? And at what level on the social status strata are these patients? Because a lot of the time, one of the things like you talked about earlier on was the resilience. And one of the things that we've always known as, people of color or those of African descent, that we have resilience. And that's been a huge issue in helping us coping with the issues that we've gone through. But as our socioeconomic status increases, resilience, we know, has to decrease. Now, is that a reason for it, or what's the all the structure, so that we know who to target and push our messages to those individuals, to those kids or those families.
Sure, absolutely. So thinking in terms of suicide, adolescent females attempt more commonly. Adolescent males complete more commonly. And the most common vehicle for completed suicide is typically firearms. So I tell folks that I no longer believe in secured firearms in the home. So even if you have to do it temporarily, if you have someone who could be at risk for suicide, I advocate removing all firearms and ammunition from the premises. One of the more common ways that suicide is attempted is by medication overdose. And that's a very common way. That's certainly more common in females than men. Interestingly enough, that is not a common way for completed suicide. As you mentioned, specifically among African-American males, as we advance socioeconomically, our risks for mental health conditions and this sounds counterintuitive, but certain physical health conditions, our risks could become higher. You would think that with more resources, we could insulate ourselves from these problems. But what's not taken into consideration are the stressors associated with these gains. And I think an excellent chapter, there's the phenomenal book by Isabel Wilkerson, Caste. There's an entire chapter devoted to the impact of racism on cancer at the cellular level and how it affects telomeres. And she actually gives an anecdote of a Nigerian immigrant who lived in the States and coming from Nigeria didn't experience day-to-day racism of the American variety. And that as their time in this country progressed, their physical health profiles mirrored those of African-American males. And there's a burgeoning literature on this, how as males, as we advance, we could develop these physical health problems. Another realm where you see this in women is with infant mortality rates, right? So those, and the common factor appears to be stress secondary to racism. So, and you mentioned earlier, Dr. Aluya, how I highlighted the importance of, it wasn't the social media, it was actually the devices. So don't take the devices away from these young people, because they still need a means of communicating with their peer group. And the peer group is critically important to adolescents. If you want to know how your kid is doing, look at their friends. And if their friends are good kids, more than likely your youngster's a good kid.
Dr. Salam.
Yes.
You mentioned you should take away the phone. What's the substitute? What do you recommend to replace that?
I said, don't take away the phone.
Don't take it away. Okay.
I'm sorry if I misspoke. Don't take away the phone, because that's their lifeline. That's their vehicle for communication with their peer group. So in the setting of COVID, folks were hunkered down in their homes with their families in some respects, perhaps spending too much time together. But youngsters need opportunities to connect with their peer group. So that's why I encourage parents, don't take the phones away from them, so that they could remain in contact with their peers.
What are the forms of punishment, quote unquote, would you recommend if you don't take the phone away?
Well, again, punishment that I'm not.
Quote unquote.
I like
quote unquote.
So,
quote unquote.
Again, setting limits, but most people don't know how to do this correctly. What's commonly referred to as grounding kids. So again, in terms of when you set limits, it should be time limited. Whatever privilege or limit you set or whatever you restrict, it should be time limited, and it should be clear how they could regain that privilege. So whether it's video games, whether it's time spent on the device, you certainly want to set limits for it, and you want to outline this is exactly what I need from you before you could have your device back, before you could have your controllers back. And one final recommendation is you don't want their device in their room buzzing all night, interfering with their sleep. So you could put a curfew on the device and charge it. The parents and legal guardians could charge the device in their room and basically turn it off. So you have the device on a schedule. Or if they have to do homework or they have to meet some other obligation, you take the device from them at that time.
Excellent, excellent. All righty. Let me see here. Dr. Salam, there's another question that came in for you. What is your professional or personal opinion of the emerging field of nutritional psychiatry?
I saw that and I knew it was coming my way. This is a burgeoning field. Again, the literature is burgeoning. What I would advise folks in terms of just basic health principles, I think Dr. Anderson really highlighted some of them. So eating more whole grain foods, fresh foods, more vegetables versus certain meats, or if you eat meats, lean cuts of meats, just dietary principles that elevate health in general. Drinking lots of water, fresh juices, monitoring your caloric intake as well as your carbohydrate intake. So those principles. In terms of nutritional supplements that you could take to enhance your mental health, the challenge is with nutritional supplements, they're not regulated as well as pharmaceuticals. So the challenge with many nutritional supplements is you don't know exactly what you're getting in the bottle if you compare supplement A to supplement B, so or brand A to brand B. So that's the challenge you face there. But I have to be honest. I'm not prescribing certain diets to folks to enhance their mental health.
Right. Excellent. Let me see if there was any other questions that have come through at the end, because I want to make sure I get most of these done. Excellent. All righty. Dr. Atherley, just give us an idea about this that came in. I have had 2 stents put in my heart, and I'm still having shortness of breath when I walk. What else can be wrong? I mean, it's a big, I understand, but if you could approach this for us.
It may be a very extensive question. Let me try to be as brief as I can in answering. To understand the background for stents, stents are devices placed in the arteries to open the artery and restore blood flow, treating the basic concern of blocked arteries. As I may have mentioned in the past, the heart is a very hard working, in fact, the hardest working organ that you've had. And it does require its own extensive blood supply. Okay? In order to facilitate that, we have little arteries that run on the surface of the heart called coronary arteries. And blockage of the coronary arteries is a kind of background situation which leads to chest pains from the heart and leads to myocardial infarctions or heart attacks, as they're otherwise called. Now, when we diagnose, based upon the patient's symptoms or other findings, when we diagnose the presence of blockage of these arteries, then there's several ways in which we approach them. The diagnosis is also important, of course. The ultimate diagnostic tool is to pass a tiny tube up through the arm or the leg towards the heart, to inject dye into these arteries and take pictures of them under X-ray guidance. These pictures document for us the flow of blood through the arteries, and we can see precisely where and how severe blockages may be. We will have reached that stage of diagnostics because the patient has presented with findings or symptoms which require some further approach. In other words, the patient may have had a positive stress test, a positive exercise test. The patient may be having severe pains. The patient may have had a heart attack. But something leads us to this level. So that when we reach that level of sophisticated inquiry, we then decide, well, there's something that has to be done. We may have already pre-planned with the patient that if we see these blockages, then we can fix them. And what we do to fix them is putting a stent in, or stents, into the area of the blockage, blowing it with a tiny balloon so that we squash the blockage, which intrudes inside the artery we squash that blockage back into the wall of the artery, and then we fix it there with a stent, which is a small wire mesh, something like the, for those who still remember ballpoint pens and springs in ballpoint pens, some of the little spring that you see in a ballpoint pen. We leave that implanted in the artery. Now, the main idea of doing this is to reduce the potential for blockage of the artery and reduce the associated symptoms, not the least of which is chest pains. If, as the questioner has asked about shortness of breath, it is not intended to directly relieve shortness of breath. If the shortness of breath is an equivalent or is secondary to blocked arteries, then it may relieve that. But the fact is that many patients, by the time they come to receive these stents, may have suffered damage to the heart muscle. And it may be in his instance that the damage to the heart muscle has weakened the heart. And so while the stent could try to prevent future occurrences, future events, new blockages, new heart attacks, etc., the stent itself will do nothing to prevent the consequences of already permanently damaged muscles, such as a heart attack. So if the patient has already suffered severe damage to the heart muscle, and as a consequence of this weakness, has now shortness of breath or fatigue or inability to function as adequately as they would normally want to, then the stents, unfortunately, may be a little late in preventing that. They can prevent future events, but may not prevent those earlier consequences. Therefore, if this patient, if the individual who's asking the question is concerned about restoring blood supply, then it can say, yes, successful stents may do such. But if they're concerned about diminishing the occurrence of shortness of breath, then it may be a little late to do that. If that is the reason for the shortness of breath, I hasten to add that shortness of breath can occur for a lot of other reasons, not only from the blocked arteries in the heart. If the stenting occurred some time ago, the patient did not have shortness of breath and now has shortness of breath, then it may be a way in which the blockage of these stents or new blockages may be manifest. So that is another thing to be concerned about, depending upon when the shortness of breath first occurs, and is it a recurrence of something that happened before, or is it a new finding? These all have different implications, different consequences, and different ways of being managed.
Right. And I'd just like to add on to that, Dr. Atherley, because we're talking about shortness of breath, that there are other factors as well. The heart and the lung work so closely together. And this could be, even though the heart is appropriately being managed, it could be secondary to the lung if their patients had, or the person has COPD, or if they had, or if they're overweight, morbidly obese. Or if they come to a point that they have a little fluid in between the lung and the chest wall called pleural effusion. There are many things that can cause shortness of breath other than the heart and the stents. But yeah, at another time in another webinar, we'll have to cover that more extensively between the heart and the lung. Dr. Salam, coming back on, I thank you for answering those questions. I saw that you were answering because we're running out of time, and thank you very much for typing the answers in. There are other docs that when you saw questions that pertain to you and you answered them via typing in an answer, thank you very much, because we couldn't cover all of the questions on the webinar. I'm so looking forward to continuing this. Understand that, and I will say this over the next couple of webinars, we as the physicians are going to take a month off. We're going to take the month of August off. So we will not be on the webinar in August. We will be here next month in July. And we will, after July, we will resume in September. So in closing, thank you to OBHealthy for allowing us to use their platform. We will be coming forth with some of the products of OBHealthy, just to let you know that going forward, they have an app that deals with healthy eating, weight loss, and health and wellness that's going to be offered for free in the future. So I will be giving you that information going forward once that the company lets me know that it's out there and it's available. I want all of our guests and all of their family members to go and download this app, because boy, it's built for us as a people. The second thing is every second Saturday, we will be here, except August. Now we're going to give the docs a break in August. At 1 o'clock, we will be here, and all you have to do is go to OBHealthy and hit their physicians network on their bridge and come into the webinar. And remember, type your question in. Don't be shy. Give us your question. You don't have to say who you are. You just have to get your questions answered. All right, caring and sharing. Listen, I'm going to say this today. If you're caring about yourself and you're doing better, then guess what? Make sure everyone around you is doing better as well. Share that knowledge. You understand? Make sure they take an older person to the doctor, or take grandma out to the park and let her sit in the sun because she's in the house all the time. Or, you know, a neighbor can't get to the grocery store. Go by and take them to the grocery store and help them shop. It's about caring and sharing as far as our community is concerned. All right. And the last thing I'm going to say is do not change any aspect of your medical care until you consult your physician. No one but your physician can best take care of your medical problems. All righty. I'm going to say it's such a pleasure being here every second Saturday. Thank you to each and every one of you docs for coming on and doing it with me. I just can't praise you enough for taking out the time in your busy schedules to do this. So until July next month, I'm going to say peace and thank you again. All right. Bye-bye, everyone.
Is that me?
Bye-bye.
Okay.
Is that me?
Mm-hmm.
Is that me speaking?
All right, bye.